Okay, so it's 2 minutes past by me. Shall we make a start, Delith, and
I think so.
and then colleagues can join us as we're going through the agenda. So lovely to see you all again, and nice just to be able to have the group together in July, just before we see the summer periods upon us. We've got a fairly packed agenda for today. And I can see there's a few more colleagues coming in now as well as we speak. So we've got a couple of presentations. We've got two organisations coming in to talk to us today. We're going to have a little bit of an update on funding opportunities, and then in addition, just the opportunity, there'll be plenty of time for Q&A and discussions as well as we run through. In terms of today's agenda, so as I say, two external companies. So one, Binah.AI are going to be talking to us about vital signs and the monitoring and solutions work that they've been bringing forward. And then the second presentation is actually going to be coming from a clinical perspective. From Cardiff and Vale have been working with the team looking at AI for use in mental health. So really looking forward to those items today. But probably thought it would be helpful at the start of the discussion just to remind everybody that we're really keen to hear from you and to take on board any of your agenda suggestions. And if there are topics that you would like us to be covering, then please let us know. Or if there are any organisations that you've come across that you've found interesting, then flag them to us, and Delith would be delighted to see if we can coordinate bringing those organisations along for the benefit of the group. You know, it's this is kind of our opportunity for shared learning and shared understanding. So, you know, come to us with any of the sort of wicked challenges that you're facing on a day-to-day basis, and you know, raise a flag and let's see where we can build some time in to be able to coordinate that. Anybody got any thoughts or reflections? I'll just pause for a second in case anybody wanted to come in on that. But if you do have any ideas as we're going through the meeting today, just drop something in the chat and we'll be in touch and get back to you so we can build those into the programme. Delith.
I was just going to say, I hope you don't mind just me butting in, just to say that we've had quite a few requests from people to join the group, and I know some new members are joining us today. So if anybody wants to just pop a hello and where they're from and what they're particularly interested in the chat, that would be fantastic as a way of getting to know some of our new members as well. So yeah, I just wanted to say hello and welcome to the group to those new members too. Thanks, Carrie-Anne.
No, that's brilliant, Ellie. Thank you. That's great. And then also, as a bit of a reminder for long-standing members, and just to raise a flag for the new members, is that we do have our own online community for the AI Special Interest Group. And I'm just wondering, Delith, if somebody could just pop the link for that into the chat, and that's an opportunity just to reconnect in a slightly more informal setting, and also, you know, another mechanism whereby people can flag opportunities or look into collaborative projects or collaborative ways of working. So take a look at the online community when you get the opportunity there. So I can just see people starting to come through on the chat. So Jim, very welcome to have you with us today, and you know, absolutely delighted to see somebody with us from the social care environment as well. You know, we've talked a lot in this group from an NHS Wales perspective, but fabulous to see colleagues joining us from social care as well. So that's amazing. Thank you. So before we move on to our speakers of the day, Dalith, I'm just going to have one last call out to you. Was there anything else that you wanted to raise with the group before we started?
No, thank you for doing the shout out for the innovation, the online community. I'd love to see more engagement from people on that. I just have to say that that's one of the places that I post quite a bit of sort of the exciting news, the, you know, hot off the press. So if you're looking for opportunities for collaboration and those sort of funding opportunities, or just a place to ask a question, then that's a really brilliant place to start off. So I'd encourage lots of people to get on board with that. And if you get any problems signing in or anything, just let me know and I can help out with that. Thank you.
Fab, lovely. Thanks, Dalith, and thank you all. There's lots of really good info and introductions coming on in the chat. So so take a look at that as we're running through the agenda. So if Avi is with us, could I invite you just to give us an overview of your organisation? And I think you and Dalith first met at an event in London earlier in the year, and she was suitably impressed and really delighted that you're going to be able to join us today, just to share the product that you're working on with the group. Thank you.
Of course, and thank you very much for the opportunity. It's great for us to be here and obviously share what we're doing. So thank you for that. Just to introduce myself, I'm Avi Markovitz. I'm head of sales at Binah. I'm originally South African, if you may hear, and I'm currently based in Israel. So I kind of know what heat you're going through, guys. Lots of water, it does help. So maybe what I can do very briefly is share my screen. Of course, I'll start with a presentation, a little introduction about the company, give you a live demonstration of the product itself, and then I'll open the floor for some questions, and then we can discuss some use cases beyond that. So without further ado, give me a sec. Let me share my screen. All right. Can everyone see my screen?
Yeah.
Yeah, that's great. Thank you.
Fantastic. So just quick introduction about the company. We have David Maman, who is our CEO and CTO. He is a serial entrepreneur, and this is in fact his 13th startup. He's closely supported by Michael and Costa, who collectively have 45 years of signal processing experience. Signal processing is the key technology in our application. It gives us the ability to measure the flow of blood beneath the skin using the reflection of light on the skin. Then we have Dr. Navetov, our Chief Medical Officer, as well as Dr. Shirasimis, who handles regulatory affairs, and a strong executive team beyond that. We were founded in 2016. We have offices in Israel, the US, and Japan. And right now we're sitting at about 130 clients across the globe in healthcare, insurance, and wellness. We've also won multiple awards for our software. So in terms of what we're doing, we essentially are removing the need for these hardware devices. They can be quite cumbersome. There's a lot of costs. Shipping, logistics is an issue. And then, of course, there's also a usability limitation. Sometimes people just struggle to connect one of these devices via Bluetooth to their phone. So we designed this software. Can you all see my mobile phone?
Yes, thank you.
All right, brilliant. So this is our application. It is a demo application because we are in fact a white label solution. So we have an integration for Android, iOS, the web, as well as React Native and Flutter. So let me open it up so I can show you what we're doing. So this is the first of the two mechanisms. It's called RPPG, or remote photoplethysmography. Through AI and machine learning technology, as well as some deep learning, we're able to detect the face using the frame. And after about 10 seconds, I'll get a heart rate, 30 seconds oxygen saturation and respiration. Now the time frame is customizable from 30 seconds to 3 minutes, depending on which parameters you would like to capture. The app itself is running on the edge, meaning that there is no need for internet connectivity. Furthermore, when you purchase the SDK, you become the owner of the end user data, making us HIPAA and GDPR compliant, thus removing the data privacy issue. Now, at the end of the measurement, we'll generate a smart report, which is essentially real-time data. And that includes blood pressure, both systolic and diastolic, heart rate variability through normalized standard deviation, and mental stress. So we should see that imminently the distance between my face and the phone is an arm's length, or about 40 centimeters, give or take. So there's the smart report. Each parameter is highlighted over here. And if you click on the learn more of each parameter, built into the SDK is all of this content related to each one, as well as this graph over here to show you if you're in a healthy range or an unhealthy range, for instance. So that's the first of the two mechanisms. The second is through the finger. Now, what we've done here is we've created a camera, and the reason for this is because I don't know if you can see me on the camera screen there. Smartphones today come with multiple lenses at the back, so you need to know you're covering the correct lens. So as soon as I cover the correct lens, I can hit measure now. It begins measuring all the same parameters, all in the same time frame. The only difference through the finger on the back camera. Sorry, that was my Samsung bugging out. They have some internal software. Anyway, you're using the finger over here, and you can take this measurement late at night or early in the morning. And if I remove my finger, you'll see there's immediately a warning message. There's about 15 different warning messages of how to use the software correctly. Okay, so those are our capabilities. I'm going to pause for a second and see if there's any questions. Otherwise, we can go on to specific use cases. All right, so we can go on. Now, in terms of Binah, as I mentioned, we do have clients around the globe, ranging from healthcare, insurance. So on the healthcare side of things, we're talking about wellness and preventive medicine, telemedicine, remote patient monitoring, elderly care. And then for pharma companies, we're using it for virtual trials, medical adherence. And then for insurance, there's a few different use cases, but I don't know if it's too relevant right now, unless there's some health insurance companies on the call. Is there any use case that I should focus on for anybody? No. Okay.
So maybe not the insurance one. Let's look at the healthcare case.
All right, of course. So we are now working with Clalit. I don't know if anyone's aware of Clalit, but Clalit is the second largest HMO in the world. They are the largest in Israel, and they're using Binah to avoid bed blocking at a hospital and clinic level. So someone will go into the hospital or clinic, get checked out. If they're not so severe, they'll send them home with an application prescribing them to measure themselves 2 or 3 times per day. And if there are abnormal results, then this person will essentially get a consultant reach out to them and determine what the next action item will be. Is it to get them to come back on their own wheels or by public transport, or is an ambulance required? That's Clalit. We also now work with a couple of hospitals. One of them is St. Luke's in the Philippines. We also have a telemedicine provider out of the Philippines called Aventus. And then this one is quite interesting, Datos. So Datos is a telemedicine company, and they provide a back-end solution for doctors. A doctor will then determine the notifications that he would like to be sent if someone trespasses beyond a specific range on a specific parameter. So they can customize those notifications, and you could just put that into an application. And again, once someone passes the certain threshold, then they would be notified. A consultant will reach out and determine what the next action item will be. So those are a few use cases in play that I can share today. There are a couple of others which we're under NDA at this point. Now, with Binah, we are a technology, so you can integrate our white label solution into your own application or solution, and you would never know it's Binah. And you'll have access in 60 seconds to a range of parameters which up until now wasn't really accessible. So this is where we are today, and it's really showing pretty good results across multiple markets, and we'd be excited to work in the Welsh market too, if that's something that's available. Now, I'd like to maybe touch a little bit on the sympathetic stress and parasympathetic stress. These are some new parameters related to, of course, stress, and they talk about how your ability to recover, being the parasympathetic activity, and the sympathetic stress is a more in-depth analysis on stress. So if someone has the ability, a high parasympathetic stress, it means that they can recover quickly from a stressful situation. Hence, that not being an issue to flag. But if someone has low parasympathetic stress and high sympathetic stress, then this could be a cause for concern because they will not recover quickly and they are actually suffering from stress. And you can determine this in 60 seconds using the selfie camera on your mobile device. All right, so I mean, we discussed the technology, we've discussed various use cases. I mean, you can use Binah as part of a wellness program. These wellness programs are being run by a lot of our clients at the moment as part of a preventive medicine or for insurance claims protection scenario. So what Binah does is it does provide you with objective data which you've never really had access to. Usually these wellness programs, they're more based on questionnaires and quite subjective. And with Binah, you can combine the questionnaire as well as a measurement, and that creates your benchmark. So if someone gets a measurement and their benchmark is around, let's say 7 out of 10, and they continue that around that number for the foreseeable future, let's say 2 or 3 months, and then suddenly you see a drop in their scoring, and suddenly it's 4 out of 10, this is a cause for concern. And once you see that drop, you can have analytics in the background to follow up on this person, try and understand what's causing the sudden drop in their health score or wellness score, and try and help them, because it has been proven that if you're proactively assisting people, let's say with mental stress, then it's much cheaper and obviously much easier to overcome such barriers in such a scenario. So that's a little bit from my end. I hope you enjoyed it, and if you would like, I can put my email address, or maybe Dilith will like to introduce us via email and we can have a discussion further if there's any interest.
Thanks, Avi. Thank you. So I can see that we already have a question in the chat. I'm wondering, Malcolm, if you'd be happy just to come in and ask your question directly for the benefit of the group.
Yes, hopefully you can hear me. Yeah, really interesting presentation. Thank you very much. Obviously, one of the things that alerted me to the fact that you're doing things or trying to do things differently was in one of your early statements about the fact that you actually don't need the internet, and that obviously it can therefore be a tool for people's self-management without having any fears about the sharing of their data, let alone all the complications that go with the consent and levels of consent that they might wish to give, or conditions that they might want to apply for the use of their data, which led me then, of course, to the question I've just put in the chat there about obviously there's the ability to share that data, and clearly there's many health and analytical organizations that would want to have access to that data to use for various purposes, if it's not only just for the person's individual health management, but also for the AI and machine learning type analyses as well. So I just wondered how far you've gone with the notion of people having ownership of their data, and how that can be safeguarded and maintained in a context of data sharing, really. That's what it amounts to.
Okay, thank you, Malcolm, for the question. And just in terms of data, what we've done, and we are essentially a B2B company, we don't work directly with the general public. So we provide the SDK or our feature, and it kind of slots into or integrates into an application. Now, let's say the NHS, for instance, were to take Binah up, they would own all of the data, but obviously with the data privacy regulations, they may need permission from a particular individual to utilize that data. If they don't get the permission, then that's okay, but we're not involved in the actual storage of the data. All we do is make that data available in real time. Okay, and we never have access to that data. We cannot see your face, we cannot see your heart rate, your blood pressure. That all resides inside of your mobile device until the organization that we're working with ping that device and retrieve it, obviously within regulations, of course.
Okay.
All right. I hope that's a good answer for you, Malcolm.
It is, but I want to ask you some more, but
Go
yes,
ahead.
your email would be useful.
All right, you can go ahead, sure. We can continue the discussion around the data because we are HIPAA and GDPR compliant. We never see that data. So I think it's if any organization in Britain would be working with us, then they need to follow the regulations of their local territory. We're a global company, and it's hard for us to follow regulations across every single continent, country, and then things change so quickly. I mean, you can see with Brexit, or slowly, I don't know.
Yeah, the reason I chuckled there when you talked about local regulation is because there's quite a strong push from UK government to ensure that data is, for want of a better word, harvested from people's health records and things like this for various commercial ends. And so that's probably one reason why I'm concerned about the issue about privacy and control and consent and all this kind of stuff. But I hear what you're saying, that you're not actually directly involved in that. That would be down to local legislators and regulators and what have you to ensure that the right kind of frameworks are in place. But at least I guess in Wales, because we have got obviously some devolved powers, it may be possible that we could put in certain frameworks which would give extra safeguards than those that might be envisaged in Downing Street or Westminster.
Exactly. So just to answer, I see Jim Wright also asked about the data. Jim, we actually never see any of the data itself, and that would be our client on the other side controlling the flow of the data. And as Malcolm mentioned, there's certain regulations around data privacy, so they need to adhere to those and make sure that they have the consent of the end user before extracting that data and utilizing it. But we have insurance companies that work with us, and they use Binah at the point of onboarding of life insurance, for instance, and they use it for underwriting. But that again requires the approval of the end user. But we're just a software, and we make it available in real time. So I know that data is obviously top of everyone's mind.
Thank you, Avi. And I'd just be interested, are you working in the UK at the moment? So is your product being utilised in the UK currently?
So we actually have a lot of interest coming out of the UK, but at the moment, not just yet. We have had a few discussions with the NHS too, and a couple of other parties, but the UK does tend to be a bit slowing moving than some of the other countries we work with.
Okay, brilliant. Thank you. And Mark, I see your hand up there.
Yeah, thanks, Karen. It's I guess more of an open question, not necessarily to yourself, Abby, but to others on the call. Does anyone know what the sort of strategy or direction that DHCW, so Digital Health and Care Wales, are taking with regards to the patient app that's been developed there? Are they looking to be able to incorporate technologies such as this? I'm sorry, I'm not cited on it, so I'm not quite sure what the plans are for that and whether or not that might be an obvious conversation to have.
I can probably respond to that, if that's all right. I know that is something that they're planning on. I think they're looking to launch the app towards the end of this calendar year, and I think that the conversations there are that they're quite interested in looking at the potential to integrate various apps onto that, the NHS app. So I think the conversation's there, and that's something that we would definitely be interested in raising with them, just to ensure that we could potentially do that if it was recognised that this was something that we wanted to implement on that national level. So yeah, I think there is that potential for being able to do that.
That's great. Thanks, Del. Yeah, I guess that obviously sits more your end than mine, as it were. But I am hoping to get a little bit closer to that app and understand more about it. But at the moment, I'm afraid I just know it's something that's planned. I have no knowledge about the detail or approach.
Yeah, no, and actually, Mark, that may be something we could add for a future agenda item once there is a sort of a more formal rollout plan prepared. So maybe in the autumn, Delith, we could pick that up. Brilliant, thank you. Okay. So I'm not seeing any more hands at the moment. I'll just pause for a second, just in case anyone has any final reflections. No, but Avi, thank you so much for joining the meeting today. That was really insightful.
My pleasure.
And it sounds like there's an opportunity for further follow-up, probably after the summer period, and please keep in touch with us. And I know from conversations with Delith earlier this week that she has thoroughly enjoyed having access to the system and being able to trial and utilize it, and has been incredibly positive about the tool just to support general wellness and well-being. So you've definitely got one advocate on the call.
Just one. But what about you, Carrie-Anne? Maybe you could also be an advocate, so then we'd have two.
Yeah, no. Well, this is the first I've seen it, so that's fantastic. But yeah, so really interested. Thank you very much, Avi.
Thank you, Carrie-Anne. Thank you, Delith. Have a lovely afternoon and look after yourselves.
You're welcome to stay with us for the remainder of the meeting if you're interested.
All right. Thank you.
Thank you. Great.
Bye.
Thank you. And we're now going to move on to hear about AI for mental health, and hear about a tool for diagnosing neurological disorders such as ADHD. So I can see on the screen that Grigoris is here and ready with us. So the floor is yours. Thank you very much.
Okay. Great. Thank you very much, and thanks for having me here. So I'm Grigoris Antoniou, Professor of Artificial Intelligence at the University of Huddersfield. So let me try to share my screen. And I hope you can see it.
Yeah, we can see it. I wonder if it would be possible just to put it on a slide. There we go. That's perfect.
Yeah,
brilliant.
Thank you. Right. Okay, so and the work that I'm going to present is has been developed in collaboration with Southwest Yorkshire NHS Trust, and it's about, well, we have a range of projects around AI supporting diagnostics of mental health conditions, but the one that I'm going to talk about a little bit today focuses on adult ADHD. And it's important to stress that this is not a technology looking for a solution, but we started this collaboration from day one, working with clinicians, to develop a viable product. So why ADHD? Well, it affects a significant proportion of adults. Okay. And actually, there has been a recent surge in demand, and on the other hand, capacity is not able to follow. Okay, and what I've heard is that after the lockdowns with the pandemic, the demand actually has grown very strongly. I don't know whether it's true in Wales, but definitely in this part of England, it has been the case. So and from what I understand, that's what our NHS partners told us. It is not easy to increase capacity because there are not sufficiently, sufficient numbers of trained specialist clinicians. Okay. This means that services are experiencing excessively long waiting lists, and we know that this is bad in terms of comorbidities, recidivism, cost to the NHS and the state. And so the hope is that through early intervention, we get to better outcomes. I will just try to illustrate the core idea. So at the moment, what happens is that people are referred for assessment from primary healthcare to secondary healthcare. And those people, and then we have the senior clinicians, specialist clinicians, which is the scarce resource. What is happening at present is that first, every new referral is seen by junior clinicians or specialist nurses, and they do data collection exercises based on validated scales and clinical interviews. And when this is over, the data is passed to the senior clinicians, and the senior clinician has to see each and every patient, and based on that, deliver a diagnosis of yes, it is ADHD, or no, it is not ADHD. And if it is ADHD, talk about treatment. If it is not ADHD, then signpost perhaps or return to primary healthcare. So this is a kind of no and yes. All right. How is the AI, our AI tool meant to work? You have the people who are referred and the scarce resource, senior clinicians. The first step is exactly the same, no change here. So every referral is seen by junior clinicians, especially nurses, for data collection. But then the data is fed into the AI, and the AI has the possibility for clear-cut cases to provide a recommended diagnostic outcome. I say recommended diagnostic outcome because it is always meant to be under clinical supervision. So we're not doing automatic diagnosis, we're providing clinical diagnostic support. So there are these cases which are clear-cut, and they can be closed obviously by a clinical person, but not necessarily by those who are, mostly also the real experts. Okay, and it's only the cases where the AI says this looks like a complex case, and we need, it needs to be looked at deeper. That's the cases that are fed to the senior clinicians, meaning that we let the scarce resource and the critical resource focus on the most complex cases. All right. So in summary, the AI tool has three possible outcomes. It looks like a yes, it looks like a no, or it looks like a complex case, for example, because of potential comorbidities with other mental health conditions. Okay, and this needs to be seen deeper. All right. So by doing that, you see that 40 to 50% of the cases can be closed without using the scarce resource. And that's where we see the most benefits from, and we expect the most benefits from. Right, so just a word about how the technology works inside. I will not say too much about it. What I'm going to say is we have two models. One is the nowadays standard of using machine learning to learn from past cases and predict future cases. But we also have a knowledge-based model, which means that, in a sense, we tapped the minds of some of the senior clinicians, experienced clinicians, and we asked them, how would you identify and propose to close straightforward cases based on the data without seeing the patient? And we got a model there as well, and we let them work together to provide, so to speak, a unified diagnostic outcome. Okay, and the overarching idea, of course, is that if they don't agree, we say that this is by definition a complex case. So so the AI is not certain about the outcome, so it needs to be looked further. But if both models agree, this, in a sense, increases the confidence that we can have in the proposed outcome. Okay, so we've run actually a pilot study at an NHS trust, and that was work that was funded by NIHR or NHS AI Lab. I'm not entirely sure because they had NHS AI Lab, NIHR, NHS X. It was the first call of on AI for health and care. Okay, and so we saw a cost reduction, significant cost reduction, and I can explain a little bit where it comes from. It comes from that not only are the senior clinicians the scarce resource, but they also by far the biggest cost. So they cost the most in terms of personnel. So if you are able to close a case with junior doctors or with specialist nurses, plus the AI tool, you have less costs. And so there was an average saving calculated and a total saving that we saw over a year. And of course, we also saw a significant increase in throughput of cases because that's what you would expect. All right, so business model is not interesting. I should say that this is a tool that is based on routinely collected data. So there is no expectation, but that a healthcare service will need to collect more data that they are supposed to collect today based on NICE guidelines. Okay. The other thing that I should say is that the tool not only provides a proposed diagnostic outcome, but also an explanation why it is the case. For example, it will say that it looks like a yes because this and this indicator are above threshold, or this looks like a complex case because there may be comorbidities, other comorbidities that are in place. All right. And so in a sense, it could also potentially, we have not done it yet, be used even for training clinicians. All right, so just to mention also that we're working on solutions for diagnostic support for autism, screening tool for autism, and also suicide risk assessment, but we certainly don't have time to cover anything today. And in terms of key people in our project, we're working with Professor Marios Adamou, who is a consultant psychiatrist and lead of the Southwest Yorkshire adult ADHD service. And then we have a business advisor, Judith Parry, and commercial expert also in Sandra Old and so on. So I should also mention, perhaps interesting, that we have filed for a full patent application, UK and international. And the only thing that I forgot, I was minding the time, I just wanted to go through things quickly. The way that the tool is used is a simple online form, system, right? Like such services will be might have used with Moxo, for example, or with Qubitest, okay? And all data that we ask to fill, and it's not too much, that is completely anonymous. So there are no issues in terms of privacy. And let me stop at this moment so that we have some time for questions.
Fantastic. That was really, really interesting. And actually you're covering a topic that is close to my heart within my family. So sort of first-hand experience of just the waiting lists and the time implications around this kind of assessment requirements.
There's one point, if I may, because there's these key points. One of the key points is I understand that in some areas, even healthcare providers are now so desperate that they try doing quick and dirty solutions. So what I'm saying is this tool provides a diagnostic recommendation at the correct level of quality. Okay, so we're not making any kind of reduction in the quality of diagnosis.
Fantastic. And then how many cases have you been able to evaluate currently to be able to assess the accuracy of the AI?
Around 400 to 500. Okay. And the accuracy has been around 97-98%. Okay. Now, if you say, oh, this looks too good to be true, I remind you that one of the three outcomes requires further assessment, right? I mean, so it's the complex cases, because the technology is not there to replace clinicians. Yeah, exactly. It's just to help them, be deployed where they are needed most.
Yes. Yeah. Fantastic. Great. Thank you. Shall we see if there are any questions around the room? Mark, I see a hand.
Thanks, Kerry-Ann, and hi, Grigoris. Nice to speak to you again. I know you're going to be talking to colleagues within Cardiff University and Cardiff and Vale soon, so there may be an opportunity for us to work more formally together in the future, which would be great. But I was just sort of wondering, apologies if it was touched upon, but as the tool develops and it can be used to support sort of diagnostic decisions, where does it sit in the regulatory space and the sort of medical device categorization?
Yeah. Thanks for this. This is actually a question where we're trying to learn. So on one hand, we had even input from one of the members of, excuse me that I don't remember the regulatory body, that talks about these things, something in the UK. Yeah,
MHRA. Yeah,
exactly.
Yeah.
And so he, Carlo Berti, and he suggested that he doesn't see regulatory problems or issues because we're providing decision support. So it is under clinical supervision. A clinician will close the case. However, in discussions that we're having, this always is flagged up. So it may be that at some stage we will need to look further into it. Okay, so in a sense, I'm not sure whether Qubitest, for example, or Moxo have done through these issues. I would need to talk more with my clinical colleague Marios, who couldn't be here today, I think. Yeah.
Really, you're very, very aware of this, and it's something that you can follow up. I think that there is some MHRA sort of flowchart guidance. I'll see if I can find the link and I'll pop it in the chat for you. It might be of interest.
Sure.
Great, thank you. And Malcolm, did you have a question?
Yeah, one of the problems with AI, or rather more certainly with machine learning, is the issue of explicability or explainability. Now, you mentioned, Grigoris, about the output of the AI actually also giving advice and an explanation as to how it reached that particular decision. When I say decision, I mean advice, I meant really.
Sure.
Can you tell us a bit more about the depth of that explanation and whether or not it's a bit of a myth that that machine learning is necessarily a black box which others cannot understand?
Right. Okay. So there's various questions, sub questions in your question. So one is machine learning unexplainable, right? I mean, and the answer I think is no. Actually, it's a hot topic, though. Just to extract as much as possible. Just also to mention that some algorithms for machine learning are easier to interpret. For example, decision trees. And some are more difficult, like deep learning, okay, or random forests. But there is it is a hot topic, but I think there are emerging solutions for that. The second is the second point is that in our case, explanation basically is extracted from the knowledge model, because the knowledge model itself has rules of the form: if you see this and this and this, then it looks like a yes. If you see this and this and this, looks like a no. If you see this, those, and so on and so forth. So then we can extract explanation based on the knowledge model, because knowledge models are by design, by definition, explainable. Okay, so I hope I answered both questions in a sense. And I said that we deploy both machine learning and knowledge model, but if they disagree, we say go to the expert, right? But where they agree, the knowledge model in a sense is best placed to provide a good explanation about why it is a straightforward case and why it is a recommended outcome. Now, the level of detail was also a question that you had. We don't, how should we thought a little bit among ourselves, right? I mean, we could provide a very detailed explanation, meaning that after running it with 20 or 30 cases or 50 or 100 cases, someone could basically re-engineer our knowledge model at least, right? And we were still in the process of protecting it. So I think we tried to get it down to a level where it is meaningful to the clinician, but does not disclose 100% the model. For example, we may not say what the threshold is, but we say that, if this indicator is high, this looks like a yes, and a clinician will say, yeah, okay, I understand that, right? And the other way with no, but we can also say that based on the questionnaires, this and this, it seems that this person might also have this and this other mental health condition, and I'm not an expert and please correct me if I'm wrong, but from what I heard is that ADHD is something that is diagnosed if it's not something else. It's not something you say, it's either, psychosis or ADHD, if it looks like psychosis, if it is psychosis and ADHD, it is a psychosis, not ADHD.
Sorry, can I just quickly come back on that one? You mentioned, Grigoris, about perhaps not disclosing the detail of a threshold, whether the threshold has been passed, but you would just say it has been passed. Shouldn't we be aiming for 100% or near 100% explicability, bearing in mind the doctor sitting in his or her surgery is going to be quizzed by the patient saying, well, how did you reach that decision? And that doctor may well be saying, well, obviously I've got the AI analysis, the machine learning and so forth, and this is suggesting this, but actually, because of other complicating factors, comorbidity, things like that, actually, that might not be the right diagnosis. So in terms of being able to explain something to the patient and the patient being able to understand and being able to trust the way that the doctor or the consultant is making their decision, then there needs to be an openness, or is some of this information proprietary that we're not going to get to know?
Yeah, thanks. I think that's a very important question. And what I can say is that we are at the stage now where we're looking for partners to pilot, to pilot our solution, initially free of charge, and then we'll see, right? To pilot our solution. And when we pilot, it's not just about performance, it's also about around usability. So this is something, what you say is something that we did not get in our first pilot, otherwise we would have done it. But if this is something that comes up as a user requirement, we will do it. What I'm saying is we have the full explanation in the system. So it's not, the only question is whether we choose to put the threshold in, which we can do. So it's from a computer science perspective, it is trivial. That's what I'm trying to say.
Thank you very much, and thanks for all the discussion following that presentation. Grigoris, really pleasure to have you join us today. I just wonder if it would be possible for you to maybe pop your email address in the chat, because there was lots of interest there, and colleagues can follow up then with you directly. So thank you for that.
I will be delighted to talk with anyone who wants to discuss it further or take it further. I can also bring in the discussion also our clinical lead, and so we'll take it from there. Thank you very much for the opportunity.
Thank you very much. Thank you. Thanks. Sarah, if you're on the call, can I just invite you to come forward and just give us a short funding update, and we can explore what opportunities the team could be thinking about. Thanks, Sarah.
Thanks, Carrie-Anne. Can you hear me and see me?
Yes.
Okay, I have got some slides, so I'll just share my screen. I don't think I'll go through all of them, just in the interest of time and temperature today. I'm sure everyone's had quite enough of sitting in the meeting. Oh gosh, where's my slideshow? There we are. Okay, right. So can everyone see my first slide?
Yeah, that's great, Sarah. Thank you.
So as you mentioned, Carrie-Anne and Dalith, we've obviously got a few new members on the call today. So I'm sure most people already know me, but just to introduce myself, I'm Sarah Taylor. I'm Sector Intelligence Lead at the Hub, and I look after the funding services. So this slide is just an overview of the funding service, which I'm sure many people would have seen before. So I just really want to emphasise the red text. So we do offer a bid review service, so we can review draft funding bids to ensure that they align with funder criteria. It's a really important part of our service, and we want to ensure that as many people take it up as possible. And to build on what Dalith was saying earlier about the AI-SIG online group collaboration platform, we're also developing one for our funding community. So it's a Simply Do funding group. So if you have any interest in sort of general funding opportunities, we do monthly updates on that call and advertise things like webinars that may be of interest. So if you'd like to join that group, then please let me know. We will continue to post on funding opportunities relative to digital and AI in the AI online community as well. As I've said to the group before, if you do want to use our funding services, if you could get in touch with us at hello@lifescienceshubwales.com, we can then arrange a meeting to talk about your requirements. We can perform a triage of your funding bid. We can signpost you to opportunities and provide other general bid support. So in the next few slides, I'm going to quickly whiz through some opportunities that are currently open or expected to open soon. So these are grant opportunities for funding. So the first one is the biomedical catalyst. So this is an upcoming opportunity. It usually opens 3 times every year. The next call is expected in August, and it provides funding to help businesses in collaboration with other organisations test and develop health and care projects. So it includes the digital technology catalyst, so it supports digital health products as well. Now, Innovate UK have told us that they are currently consulting on this funding stream, and it may well be redefined and expanded next year. So this year is likely to be the last opportunity to apply for the biomedical catalyst as it exists now. It is good news that they are considering expanding it, but we don't know what the scheme will look like from next year onwards. Another Innovate UK opportunity that's upcoming, which you may have heard about at Medi Wales. I think David Kunar talked about it there. So it's the Launchpad scheme. So they're currently piloting some Launchpads. It's different to the previous Launchpad programme in that it's a significantly larger sum of funding. We anticipate that they're going to launch a new funding stream next year as well. We've got limited information at the moment, but we think there will be funding for emerging clusters which build on existing strengths, and that there'll be support for particular areas of need, but we don't know what those are as yet. So another Innovate UK upcoming opportunity, the Health Technology Regulatory and Innovation Programme. They had to close their last scheme early because of the number of applications. We are anticipating a further 2 million being assigned to this very soon, and a second round of funding being launched. So that's upcoming as well. So another upcoming opportunity that I think I've mentioned to the group before is the Moondance Cancer Initiative's Early Detection and Diagnosis funding programme. So we're expecting that as well to launch over the summer at some point. They do run regular calls for other areas, and they are open to approaches for funding at any time. So just to flag those up as well. Now, I always mention health technology assessments, so I'll do it again. So the health technology assessments are a really good opportunity to evaluate new technologies at a late stage of development. So that's comparing them with existing technologies. NIHR have got multiple calls open for applications, and we expect some more calls to be advertised late next week. So I'd really encourage everyone to check the NIHR funding web pages for full details. Some of them are really specific. They do have general researcher-led calls that are open to any specialism. We would be really happy to help you apply for those. And if you're interested, then please do get in touch. So another opportunity that's open at the moment is the DASA Generation After Next Wearable Technologies. So they're providing funding for early research, so TRLs 2 to 4, into devices which are capable of accessing molecular biomarkers in body fluids, or for assays capable of performing continuous measurements of molecular markers in body fluid matrices, or for the assessment of the applicability of accessible body fluids to measure particular biomarkers. Those 3 criteria are a bit of a tongue twister, but there we are. That's what they're looking for. So applications for that call close on the 25th of August, and they've got a total of 750,000 available for multiple 12-month projects. And I just wanted to mention as well, so levelling up is obviously potentially a key funder in the future. The Shared Prosperity Fund is currently under development with the UK government, and the local authorities in Wales are currently consulting on their spending plans for the Shared Prosperity Fund. So their spending plans need to be returned to UK government by the 1st of August, and several local authorities have opened up a consultation process. So if you do get the opportunity to feed into the consultation process, then please do take it so that we can ensure that life sciences, digital health and so on are represented in this first stage, because this is going to shape what funding is available in the future. So yeah, I'll leave it there. That's it from me. Just to emphasise, if you do want to get in touch, you can use the Hello at Life Sciences Hub email address, or you can contact me directly if you prefer.
Thanks very much, Sarah. Thank you, and apologies everybody, we've overrun slightly, so rather than taking any questions now on funding, could I ask Sarah if you could just remind everybody of the email address in the chat, and if you're able to, if you have any questions or queries, then please get in touch with Sarah directly, and in particular if you're interested in joining that that finance community group as well, to have regular updates on this kind of information. So I'm not going to keep you any longer. I know a number of colleagues have already needed to leave us. We next get together on the 13th of September. So that probably just leaves from me to wish you a lovely summer period, and we'll see you again in September. But if you have any reflections to share, then please get in touch, and if there are any agenda items or topics that you'd like us to cover, then please drop an email to Delith, and we'll see you soon. Thank you all very much. Bye guys.